Hello, and welcome to the webinar, Optimizing the Management of Early Stage TNBC Symptoms, Treatments, and Recurrence. I'm Megan Claire Chase, Breast Cancer Program Director at SHARE. Now, please share in the chat where you're from today. We'd love to see where you're coming from. Before the presentation begins, I'd like to tell you a little bit about SHARE. SHARE is a national nonprofit that supports, educates, and empowers anyone who has, hold on, just lost my place there, who has been diagnosed with women's cancers, and we provide outreach to the general public about signs and symptoms, because no one should have to face breast cancer, ovarian, uterine, cervical, or metastatic breast cancer alone. For more information about upcoming webinars, support groups, and our helpline, please visit our website at sharecancersupport.org. Now, all participants will be muted during this presentation. Once Dr. Hampton finishes presenting, we will begin the Q&A discussion. So feel free to engage in the chat with comments and ask any questions for our presenter via the chat or through the Q&A section at the bottom of your screen. Remember that Dr. Hampton is unable to give specific medical advice, so please keep your questions general in nature. We also have closed captioning available. You can enable this feature by clicking the live transcript button at the bottom of your screen and selecting the subtitle option. This webinar is being recorded and will be available on the SHARE website soon. So now I'd like to introduce you to today's speaker. Dr. Regina Hampton is a board-certified general surgeon with a focus on breast health and breast cancer in the DC metro area. She is the medical director of the Breast Care Center at Doctors Community Medical Center, Luminous Health, the first breast center in Prince George's County. She was elected the first female medical staff president in the 40-year history of the hospital and co-founded and chairs the weekly Breast Cancer Case Conference. Dr. Hampton is also the medical director and co-founder of the Breast Care for Washington, a nonprofit dedicated to providing access to screening mammography regardless of the ability to pay. She attended the Medical College of Pennsylvania, now Drexel University in Philadelphia, and is a member of the Drexel 100 Distinguished Alumni Hall of Fame. In 2018, Dr. Hampton co-founded Cherry Blossom Intimates, a bra and lingerie store and mastectomy boutique with products customized for diverse skin tones and body types. Dr. Hampton is the only physician in the country who is a certified mastectomy fitter. This proud wife and mother of one son is a member of Delta Sigma Theta sorority and the Lynx. Dr. Hampton has been featured in the Washington Post regarding Black women and breast cancer and in Essence magazine, along with TV and radio appearances on NPR and the Respar Morning Show, and has been featured on Own Your Own Health for breast cancer awareness on the Oprah Winfrey Network. What? So, Dr. Hampton, the screen is yours.
Thank you. Thank you so much for that wonderful introduction. Good afternoon, everyone. Pleased to be back and excited to be invited to come back and share and present. So I'm going to share my screen and we are going to get ready to roll here. All right, so we're going to talk about optimizing the management of early stage triple negative breast cancer. So triple negative breast cancer accounts for about 10 to 15% of all invasive breast cancers that we diagnose here in the US. It is considered one of the most aggressive subtypes. And the reason why it's unique is because it's not responsive to hormone-based therapies like tamoxifen, arimidex, and letrozole. But I think there's some good news when we talk about triple negative breast cancer, in that we now have better overall survival. And that's because we have now what we call neoadjuvant regimens. So we're going to talk about that. So first, let's talk about what is triple negative and try to explain it with some graphics here. So I think the best way to understand triple negative is to understand a hormone positive tumor. So you can see here on the far right, tumor cells can have, I call it like a grabber spot or a receptor, an area where our natural hormones, estrogen and progesterone, can bind to the tumor cell. And then in the middle, where it shows it binds to the tumor cell, it sends signals to the tumor cells to keep dividing, keep growing, keep spreading, keep doing your thing. And then these patients that have that hormone responsive tumor, they're eligible for a hormone-based therapy, where what this medicine does is it blocks that grabber site, that receptor site, so no more of our great hormones can get into the cell. That blocks that signal, cuts off the food supply, so that those cells have less of a chance of growing. So what this does is it helps to lower the risk of the cancer that was treated coming back, and helps to lower the risk of any new cancers to form. Now, the benefit for these patients is they get to be on these medicines for 5 years. And so this medicine is active for 5 years and helping to keep that cancer away. And it works so well that now there are many regimens that are, and many oncologists who are recommending that patients can be on these medications for 10 years. Now, let's reverse that and talk about what happens when we have an estrogen negative tumor. So what happens is we don't have that receptor on the cell. And so these cells, they don't need estrogen or progesterone. They don't really care about our hormones. They're sending their own signal about dividing, spreading, and moving on. And that's where it makes it a challenge. And especially when we talk about long-term treatment, we don't have that pill like we do for the hormone positive patients to help to lower the risk of the cancer coming back. So let's talk about some racial disparities. I think one of the good news is that as African-American women, we actually get less breast cancer than our white counterparts. However, when we look at the 5-year survival rates, there are significant differences. So it's about 77% for African-American women and about 90% for white women. And I think, we're going to pat our white counterparts on the back because they're really moving forward and helping to lower those mortality rates for all women when we look at all the stats. When we look at overall decrease in mortality or death rates, it's decreased a lot greater for white women. Again, we're going to give them a pat on the back because it has decreased greater for white women. However, it's decreased less for Black women. So it's decreased by 34% for white women and only 2%, one digit, for Black women. And there's some reasons for this because we do know that breast cancer in women of color can be different. So as African-American women, we tend to get breast cancer at younger ages, under the age of 50. And even there's a larger number who get it under the age of 40 when we start getting mammograms. So it's about 33% of breast cancers in Black women occur under the age of 50 versus only just over 20% for white women. And to further compound that, there's more triple negative breast cancer when we talk about Black women versus white women. And then there are also just some barriers when we talk about breast cancer in Black women. So there can be delays in diagnosis, again, because a young woman will go in and many providers are just not expecting that her at 33 is coming in and we need to rule out a breast cancer. So there can be delays in diagnosis where these patients tend to go to multiple providers and they are told, oh, it's nothing, don't worry about it, it's a cyst, come back later, you're not 40. And those are the ones that we need to hone in on. Of course, we've heard about implicit bias from healthcare providers where, patients just are not treated fairly. And then there are, of course, financial factors, and this is not unique just to Black women, but, many places don't have the latest technology. There are some providers in communities of color where they're not practicing up to the standard of care and really offering all of the latest treatments that are available. So who gets triple negative breast cancer? So it can be any woman at any age, any color, any race. We certainly do see it in younger African-American women, but again, we do see it in white women as well. So what are some of the symptoms of a triple negative breast cancer? Well, we hope there are no symptoms. We really would prefer women to come in when they're not feeling anything. they're not seeing anything different, that we're just finding it on a mammogram. So she's gone in, she's gotten her mammograms yearly, and then all of a sudden we see something small. She doesn't feel it, it's asymptomatic. That's when we really want to find these. But of course, there are some women who will notice a mass, or their clinician will notice a mass, and the mass can be in the breast, or it can be under the arm in the armpit. Typically, it's going to be painless until it gets to a point where it's causing pressure on the breast. But most painless masses are the ones that we really want to hone in on. There can be some swelling, and sometimes women can present and it looks like they have an infection, but it really could be a more advanced stage of the cancer. There can be nipple discharge, a bloody nipple discharge. It's certainly something that we should check out thoroughly. Now, a lot of us may have clear, milky, even greenish discharge, and those are usually not indicative of breast cancer. There can be asymmetry where a woman comes in and says, you know, it's hard for me to fit into my bra. One breast fits in fine, but the other one doesn't. It's harder to fit in. And then there can be something called dimpling, where it looks like somebody's pulling our tissue inward, and that's something called dimpling. So mammogram, how do we make a diagnosis? Well, we certainly want to get a mammogram, and we want to not just get any mammogram. We should be getting 3D mammograms because that is the best picture that we have out there. It's really going to show us things that we may not be able to see on a regular 2D image. If you look at the picture on the bottom, on the far left, you can see that it just looks like some dense breast tissue, and all of this kind of white stuff is what we call breast density. It's just normal breast tissue. But the advantage of the 3D mammogram is that if you think of a book, you got your front page, you got your back page. Well, there might be something going on page 40 that you can't see from the cover. So what the 3D mammogram does is it allows us, when we're looking at the images on the screen, we're going to flip the pages of those books so that we can see what's going on layer by layer in that breast tissue. So you can see down below on image 36, you don't really see anything. It just looks like some breast tissue. But as you start to go through and the numbers represent the different slices, when we get to slice 43, it looks like something there that we need to check out a little more. And when we blow that up, you can see there that it's a little spiculated mass that we're going to want to get more information on. Now, some other things that we use, ultrasound, which uses sound waves, and this can help us to characterize, it can help us to give more detail. Does the mass look like it has a circumscribed edge? Does it look what we call spiculated or starburst, or is it fluid filled and like a cyst? And then there's breast MRI. Breast MRI can help us to tell the extent of the cancer. It can pick up sometimes a new cancer that we couldn't see on the mammogram. And we can use this in a lot of women that have dense breasts for screening. So how do we actually make the diagnosis? Well, we have to do what's called a needle biopsy or a core needle biopsy. And this is what's known as a minimally invasive biopsy. And this can be done by stereotactic, which is using a mammogram, or by using ultrasound. And it essentially is numbing the breast up, making a small cut in the skin. The needle goes through the skin. We take out a few pieces of the lump or the calcifications or whatever it is that we're focused on. And then we can send that out to be evaluated to give us a diagnosis. The great thing is you don't require any stitches, no hospital stays. It's done as an office visit. Usually takes about 20 to 30 minutes to perform. And then you can get the results back in about 1 to 5 days, depending on the particular lab. So what goes into the pathology report? Excuse me. So when you get a pathology report, I know many of you, if you've seen your own pathology report, it's like, what's going on? There's all these words here. What does all this mean? So what the pathology report tells us is what's the type of cancer? Is it invasive? Is it in the ducts? Is it in the lobules? Or is it in situ or a non-invasive breast cancer? And then it's going to give a grade. And what the grade does is tells us how close or far away from our normal cells do the cancer cells look. A grade 1 or a well-differentiated cancer means that the cells look pretty close to our normal cells versus a grade 3, which is what we call poorly differentiated. They're going to look furthest away from our normal cells. We're going to look at that receptor status, and we've talked about that: estrogen receptor, progesterone receptor, and then there can be a third protein called the HER2 protein. And the reason why HER2 is important is because there is a targeted therapy for patients and tumors that carry that HER2 new protein. And then there'll be something on reports called the Ki-67. What this does is it tells us what's the rate of proliferation. Is it a lower Ki-67, which tells us it's kind of slow growing, versus it higher and going towards 100, means that it's something that's turning over pretty quickly. I think some of the good news about where we are with breast cancer today is we've changed the staging. And why did we do that? Because we actually treat breast cancers a lot better than we once did. And we now have to use an app. It's hard to just kind of look at a path report and be able to stage accurately. So in order to do staging now, we have to know all those things on the pathology report: the tumor, what's the size of it, what's the grade of it, and what's the receptor status. And all those components have different weights that help to get to the staging. We need to know, is there any lymph node involvement? Is there any spread of the tumor to the lymph nodes under the arm? And then we need to know, is there any spread of the tumor beyond the breast and the lymph node, which is known as metastasis. Now, what happens is most patients are going to usually get two stages. You're going to get what's called a clinical stage, and that's our stage that we're really kind of estimating based on physical exam, based on the radiology test, MRI, mammogram, ultrasound, and we're going to do a staging based on that information. Then after surgery, we give you what's called a pathologic stage, where once we have the tumor out, we can get the actual size and get some other characteristics, then you can get what's called a pathologic stage. Now, let's take a look and just see how staging has actually changed over time. So in example number one, we have a patient. She has a 5.3 centimeter tumor, which is fairly large. She has a lymph node that's positive. She doesn't have any metastatic disease outside of the breast. It's a grade 2. It's estrogen positive, progesterone positive, and it's HER2 positive. Well, we know this is a very, very treatable cancer. Even though it's big, we know it's a very treatable cancer. And so in our old staging, this would have been a stage 3A. In our new staging, she is now a stage 1B. And this is even before even giving her treatment. Why is the staging so much better? Because we know she's going to get that HER2 targeted treatment. We know she's going to get the estrogen and the progesterone, the hormonal therapy as well. Now, because this patient has a large tumor, she's probably going to get chemotherapy before we even treat her. And guess what? Because she has a HER2 positive tumor, probably this tumor is going to wipe away down to nothing. So then her pathologic stage quite possibly might be a stage 0, especially if there's nothing left. And then you can see another example there, little smaller tumor. It's HER2 negative this time. It still has a positive lymph node. In the old staging, it would have been a 2B, but in the new staging, it's a stage 1B. So I think, patients get caught up in what's the stage? And I always tell, we're not going to on the stage on aspect. Now, there may be additional tests to do. We may need to, we talked about an MRI, which is what we see up above, but we may need to know what's going on outside of the breast and the axilla. So we'll do what's called a PET scan. PET scan is a whole body scan, which usually includes a CT scan as well. And they're going to fuse those tests together. And it looks to see, is there active tumor going on anywhere else in the body? So a PET scan can be very important. And then once we've gotten all these tests, we've gotten our biopsy, then most institutions we're going to meet. It's called a tumor board or a tumor conference or a case conference. We're going to meet, most of us meet weekly. In fact, I have my meeting this morning where we discuss my patients. And this is where we all sit around the table, or these days sit on Zoom and talk as a multidisciplinary team. So the radiologist puts up the images, the surgeon is going to discuss, the pathologist puts up the pathology slides, the radiation oncologist is there, the medical oncologist, the plastic surgeon is there, of course our nurse navigator is there, and we all sit around, discuss the case so that we can all get on the same page. And whenever we're talking to the patient about what the treatment plan is going to be, we're all singing from the same songbook, and not like the surgeon saying one thing and the oncologist is saying one thing and doesn't sound like anyone's agreeing. We usually have had those little discussions and disagreements, and then we get on the same page in the tumor board. So a very important part of the journey. Now let's just touch a little bit on genetic testing. So typically we used to test for the BRCA genes, BRCA1 and BRCA2. Those are some of the most familiar genes. But what we've realized is there are some other genes, the BARD1, the PALB2, and the RAD51D that are also related to breast cancer. And so for triple negative breast cancers, the guidelines have been updated where it says all women, no matter your age, no matter when you were diagnosed, should get genetic testing. And this is important because for those of you, if you have mothers, aunts, grandmothers who may have been diagnosed, 10, 20 years ago and had triple negative, they should actually come in today and get tested, because we really want to know if there are any genetic mutations, because that can have implications for the other members of that family. I personally recommend doing large panel tests where we can now test for up to 100 genes. Now, we don't know what to do with all these genes, but I feel that as we continue to test patients, and especially in patients of color, we're going to soon start to find some patterns that will then give us information, and then it will help us to design better treatment plans and hopefully better treatments. So treatment options for triple negative breast cancer, well, chemotherapy is the mainstay and it is number one. And we're either going to give it before surgery, called neoadjuvant, or we're going to give it after surgery, called adjuvant, and then surgery, and then radiation. And again, hormonal therapy is not an option for triple negative breast cancers. So neoadjuvant chemotherapy, this has really, I think, changed how we view, how we approach triple negative breast cancers. This is one of the most common regimens where you're going to get AC followed by paclitaxel or Taxol, and now it's given dose stints. And that instead of doing it every 2 weeks, we're going to do it instead of doing it every 3 weeks, we're going to do it every 2 weeks, because we really want to take a more aggressive approach when we talk about triple negative breast cancers. And then the Taxol is given weekly. Most commonly it's given weekly for 12 cycles. Then there's a newer medication out called Keytruda. You may have seen that in the news, or called pembrolizumab. And that is added now, and we're starting to see better response rates when you add this medication. As a example, one of the patients we talked about in my tumor board this morning, she had like a 5, almost a 6 centimeter tumor. She got the AC with the paclitaxel and the pembrolizumab. I did her surgery. She was able to get a lumpectomy. She only had 6 millimeters of tumor left. That's almost a complete response. And so we're really excited about those type of results. And then there's also a medicine called carboplatin that the oncologist may recommend in particular cases. So this is something called the NCCN guidelines, where this is really our roadmap. And most, if not all, doctors should be following these roadmaps. And this just tells us what we should do. You can see the preferred regimens are the AC every 2 weeks, followed by the paclitaxel. But there are some other regimens. Olaparib is another medication used in triple negative breast cancer for patients who are positive for a BRCA1 or 2 mutation. So you can see there are some other regimens, but the standard is that AC with the paclitaxel, and now adding that pembrolizumab. So we're going to look for the response to chemotherapy. We're looking for a clinical response. This is by physical exam, and I can tell you a lot of patients after 1 or 2 treatments start to notice that the mass starts to shrink significantly. We're going to repeat the imaging studies after the course of treatment so we can know what's left, and then that helps us to plan our surgical approach. And then we're going to look at the pathologic response. This is what we get when we take the tissue out and we look at the tissue. You can get what's called a partial response. So that patient I just talked about, she had a partial response, near complete, but partial. And then you can get what's called a complete pathologic response, where that means we do the surgery, we look at it under the microscope, and not even one tumor is left. And that means improved survival for those patients. And we know that they're going to have a better outcome when we get that complete pathologic response. So when we talk about surgery, there can be some options, and especially when we do the neoadjuvant chemotherapy, so someone who may have had a larger tumor, may have had to have a mastectomy. Well, when we do the neoadjuvant chemotherapy, we can then do a lumpectomy, or what's known as a partial mastectomy. This is where we're going to remove the tissue and the tumor and a little bit of normal tissue around it, and we're going to leave the breast intact. We're also going to check the lymph nodes. And then usually if you get a partial mastectomy or lumpectomy, then you usually have to get radiation after that. So unfortunately, when we used to do lumpectomies, we didn't do such a great job. We were removing the tumor, that was great, but we left women with some severe deformities. And so you can see the top, some of the deformities. We cured the cancer, but didn't leave such great results. And a lot of women really didn't like that appearance and really felt some kind of way, and they should have. And so they complained to us. And so we changed our approach. So you can see on the bottom left is a patient who had a tumor. And you can see she had a large breast and she had always wanted a breast reduction. So we did her cancer operation as a breast reduction. And so you can see her on the right side. She's like one of the happiest cancer patients ever, because she has new lifted breasts. Her back is a lot happier, and she's cancer free. So there's just a newer approach when we talk about surgery. We do want to check the lymph nodes, and we can do what's called a sentinel lymph node biopsy, where we're going to take out just a few lymph nodes, usually anywhere from 2 to 5 lymph nodes. Now, if someone has had neoadjuvant chemotherapy, then we're going to want to try to get at least 5 lymph nodes. And this is versus what's known as an axillary dissection, where we're going to take out a few more lymph nodes. But in this day and age, axillary dissection means going up to about 15 lymph nodes, give or take, versus taking out the 35 to 40 lymph nodes that we have. So with taking fewer lymph nodes, we are seeing less lymphedema, which is swelling in the arm. Now, mastectomy is still a great operation. This is complete removal of the breast and or the breast tissue. What's important to know is even with removing all of the breast tissue, there is still a slight risk of recurrence. It's not completely zero, even after a double mastectomy. It's about 0.5%. So that's about as low as we can get it. Now, there are different types of mastectomies. We can do a simple mastectomy, as we saw on the other page. We can save the skin so that we can reconstruct. We can do nipple sparing. We can do what's called modified radical, where we're going to take the breast and take out and do an axillary dissection. And then, of course, some women may choose to do a bilateral. And then prophylactic mastectomy is for women who don't have a history of cancer, but want to be a previvor and to lower their risk of developing cancer in the future. Now, this is something called a nipple sparing or nipple preserving mastectomy. And you may think that these are two different women. Excuse me. But if you look on the left, this was a patient. She was in her early 40s. She had a cancer on one side. We did an MRI, picked up another cancer on the other side that wasn't even seen on mammogram. And so she decided to have both breasts removed. So you don't see her scars. They're all hidden underneath the breast and under the arm. And then you can see we kind of lifted her up, made her a little bit bigger. And so this is a nipple sparing mastectomy. And so unless she told you, you wouldn't really know that she's had surgery and that everything under the skin and the nipples is missing and has been rebuilt by the plastic surgeon. So that leads to breast reconstruction. So we can build a new breast. We can use an implant made of saline or silicone. We can take one's own tissue from the belly, tissue from the back, and use that to recreate the breast. Now, breast reconstruction, while it's great, there can be complications and quite frankly, failures. So about 1 in 3 patients will have a minor complication that can be treated without additional surgery. About 1 in 5 patients will need some additional surgery. And then about 5% will fail completely. And some of the factors for the complications are, patient selection. Sometimes patients don't have well-controlled medical issues, especially diabetes, high blood pressure, smokers. Smokers tend to have poor wound healing, and so they can tend to have problems. Then our body condition. And then just psychological, it's just overwhelming. And sometimes patients may choose reconstruction when they may not be in the best frame of mind to handle it at that moment. But the good thing is you can get reconstruction immediately, but you can also get it delayed and come back at any time and get it later. Radiation is using high energy X-rays to cause death to any of the microscopic tumor cells that might be left behind. That's a sample of a machine, so the patient just lays there. You don't see or feel anything. And so radiation usually comes after a lumpectomy for sure. And then there are some patients where after a mastectomy, they may need radiation as well. So let's talk about the Women's Health and Cancer Rights Act in 1998. This is a federal law that provides protection for breast cancer patients. So this law says that insurance has to provide some coverage. Could be 100%, could be 80%, could be 50%, depends on your carrier. But it has to cover reconstruction. It has to cover reconstruction on the opposite breast. That's why our patient in the earlier slides could get the breast reduction as part of her treatment. It covers breast prosthetics. It covers bras, post-surgical bras, and camisoles. And this is available to you all as cancer patients for a lifetime. You carry the diagnosis for a lifetime, so you should have these items available. And so that's why for some patients, if they choose to do a mastectomy and don't do reconstruction at the time, they can come back 2, 3, 5, 10 years later to get reconstruction if they want it, and it still is covered under the law. And this law applies to patients whether they're undergoing or have had a lumpectomy or a mastectomy. Now, not everybody wants reconstruction, or it may not be safe for us to do reconstruction. So what we will do is we'll offer them a prosthetic. And there's something called a standard prosthesis and a custom prosthesis. So standard is on the left, where these come in a plethora of sizes. They come in 2 colors, brown for kind of a brown cocoa, or a peach or a pink color for our lighter skin women, versus a custom prosthetic where we can color match just about anyone's skin tone. And you can see here the lovely colors. You know, I say even lighter skin and white women are not peach or pink. They have different shading to their skin tone. So we really can color match just about anyone's skin tone. This comes in about 36 different colors. Then we can select the nipple. We can select the nipple size, the nipple protrusion. So really, it really is a truly customized approach. And then these are just 2 samples of custom patients that I've seen. And you can see we've color matched their skin pretty well. One patient on the left, she needed a full volume because she had a full mastectomy. And then the patient on the right, she just needed to fill in some volume that was lost after her surgery. So you can see that the color looks pretty good, and they got to select the nipple and everything. So it really is a very customized approach. So breast prosthetics are not what they used to be. It really can be have it your way and have it made the way you want it. Now, insurance coverage, it does cover the pocketed bras. So it doesn't cover just regular bras that you can go to any store. You have to get special bras from a mastectomy fitter. So Medicare is pretty generous. They give 12 bras per year. And these patients are so excited to come in every 3 months. It's like Christmas. Every 3 months, they get 3. Has no stated around some authorized. It prosthesis, and that includes the custom. You get 1 per side every 2 years. And then it covers the non-silicone prosthesis, which is called an active form. You get that every 6 months. So let's talk about some post-treatment follow-up. So surveillance, how are we going to follow patients who've had triple negative breast cancer? Well, we're going to continue to get breast imaging unless she's had a mastectomy. And if she's had both breasts removed and had bilateral mastectomy, she does need to get regular imaging, at least by mammogram or MRI. But for those women who have a lumpectomy and still have their breast tissue, we're going to do that 3D mammogram. And then depending on the density of the breast, we may add an MRI as well. Then there should be a physical exam by your doctor every 3 to 6 months for the first 2 years, and then annually. And this should also include pelvic exams as well. And then your oncologist may decide what other types of tests chest X-ray, CT scan, PET scan, and or bone scan. And it probably usually depends on the type of disease that you had before undergoing treatment. So I like to talk about what's life like after cancer, because for us on the oncology side, we work hard because we want you all to live life after cancer. So it's important that you make your health a priority. I think many times a diagnosis really makes people think about their health a lot differently. Stay active, get out there and enjoy life. Resume your enjoyable activities. Or hey, guess what? You can still do these activities while you're undergoing treatment. You don't have to wait until all of your treatment is done. We've really designed all of the treatments because we realize women want to keep it moving. I know my patients say, no, I tell them, keep it moving. During chemotherapy, continue to exercise. After chemotherapy, continue to exercise. Continue to do things with your loved ones, things that make you happy. Try, and I know it's easier said than done, try not to become consumed with the diagnosis. We know it's overwhelming. We know there's a lot to take in. You're being given a lot of information. But it's important to try and take it into small bits and realize after you've been treated, yes, is there a risk of recurrence? Sure, but that's the risk for every woman. And so it's trying not to become consumed and thinking about it at every minute of the day. I think laughter is like the best medicine. So laugh every day, laugh at yourself, laugh at somebody else. Don't take yourself too seriously and create happiness. Let's not wait for somebody else to create happiness. We just went through and got rid of all these bad cells. So we got rid of bad cells and got them eliminated from our body so we can be happy and have a happy place. Guess what? Cancer doesn't like happy places. So stay happy, stay positive, and decrease stress. I know, again, easier said than done, and I'm guilty of it as well, but we really have to look at how we decrease stress in our lives, because stress can have effect on all of our cells in our body. And think like a survivor. No matter what the diagnosis is, no matter what the stage is, think like a survivor and enjoy life. And I love this quote. It says, don't let breast cancer take away the motivation to achieve your dreams. And so even what I tell my patients is, this cancer diagnosis is one part of your life. I don't want it to be your whole life. And so we really want you to go out there and live your best life and enjoy and say, hey, I've got cancer. I've got to pause life for a minute to go get this treatment or go get this surgery. But guess what? Right after that, I'm going to get up and keep it moving. I am the co-owner of Cherry Blossom Intimates. We are a bra and intimates boutique and an accredited mastectomy facility. We also are a regular retail store. And this really came about because I found that in the mastectomy space, people really weren't paying attention to brown skin girls. And I've had women who've gone to mastectomy boutiques with brown skin like mine and being given a pink prosthesis. And that is just not right. And we're really out to change that. We also have another division of our company called Maya. And this is where we do online fitting. So what happens is we register you online. We send you out a fit kit by mail. We set you up for a personal private video fitting where we're going to sit, we're going to help you to measure by video. We're going to check your insurance as well. And then once you select items, we're going to send them to you. Any items that don't work for you, then you send them back, almost like Warby Parker. And then it's really just a way that we can reach out to more women, be more inclusive, and really to help women know that, there's so many different options available out there. So with that, I'm going to say thank you so much for having me. And I will look forward to taking any questions.
Oh my goodness. Dr. Hampton, as usual, you are amazing. And the information you presented to us today is just, you blow my mind every time. We actually have a lot of questions for you. So okay. I'm going to get into that. And everyone who is listening, we are still accepting any questions live. So you can put them in the Q&A section. So I'll take the one that was submitted in the that was submitted live. What is considered early stage?
So we consider early stage as, of course, stage 0, which is a non-invasive breast cancer. but a stage 1 or a stage 2. But again, I just don't like people to get hung up on that, because you may be diagnosed as a stage 3, but with treatment and neoadjuvant treatment, we can bring you down to a stage 1 or even a stage 0. So I try not to have patients focus in on that stage number, because sometimes that can be discouraging. But I think focusing on the fact that we have better treatments out there and we can downstage women, and we do it every day.
Fantastic. So here's another question that was submitted earlier. What percent of stage 1 TNBC patients have recurrence?
Yeah, I think that number is really evolving, especially because we have the newer medications. I think out there, the quote anywhere from 25 to 40%, which is such a wide range. But, what we realize is that triple negative is not triple negative is not triple negative. And that's where the research has to be done, is to see, what is it that's unique? Why is it that some triple negative patients, can have a little small tumor that spreads, or some triple negative patients can have a big tumor in the breast that doesn't spread? And I think it's going to come down to really biology, and I think the genetics. So I'll give a plug and say, I really hope that many women will consider getting involved in clinical trials, because I think this is the way we're going to find out what works, find new medications, and especially for women of color, to find out, is our biology different, and is that what makes our cancers different? We can't rely on anyone else to get in those studies. We have to be a part of it.
Oh, 100%. 100%. And you make such a great point of it's kind of a crapshoot in a sense, like you just don't know who's going to get a recurrence or not. So I know, because I'm also a breast cancer survivor as well, and that fear of a recurrence. So really appreciate what you said towards the end about not getting so caught up in the fear, though that can be hard, but try and just put it on the back burner, when you can, and try and just live for the now. That's what I like to tell people.
Absolutely. Yeah.
So what is some of the latest research to help address the difficulty in treating this triple negative breast cancer?
Yeah, so I think getting involved in clinical trials, the newer medication that I talked about, Keytruda, we're really starting to see really great results. The PARP inhibitors, used mostly in the metastatic, for metastatic patients, but again, starting to see some great results. So, I think it's really, I just can't say it enough. I just really think that we just have to really get involved in clinical trials where we can. You can go on to the NCI website. They have clinical trials. I know not all hospitals offer it, but feel free to ask your doctor, ask your oncologist, or look up online and find, if you're in an area that has a major university, then you should be able to find a clinical trial. So I think there's just so many answers we don't have. I'm really excited that there is now starting to be more focused. I think we figured out hormone positive tumors. I think we've got that right. And yay, again, happy for them. But, I think it's the triple negative space that we really have to make more strides on.
Absolutely. And to also take away that fear of clinical trials, especially for people of color, and just knowing the history. And I think it's important that patients know, even if you get into a clinical trial, whether you receive that medication or not, you will always be receiving your standard of care. You will never not be receiving medication. And I think that is something that still a lot of people don't realize. So glad you're mentioning this today.
And I think it's also important to note, many times patients in clinical trials can get, extra tests and extra studies. So sometimes some insurance companies don't want to pay for a PET scan. But guess what? Usually if you're in a clinical trial, you're going to get a PET scan. So it could be kind of a way to sort of get a little more imaging, a little more surveillance, if you have some concerns.
Absolutely. Let's see. So we have this question here. Is lifestyle a big factor in TNBC?
I personally think that it is. Do we have the proof of that? No, I think it's hard to really measure. And how do we, measure stress and stressors, and then be able to translate that into a number or something that we can use. I think anecdotally, just in the patients that I see, I think stress is a big factor. I mean, stress not only can affect our blood pressure. I think if it's affecting our blood pressure and we don't know it, because it can be, the silent killer, what other effects is it having on the cells in our body? So, my thing is, trying to decrease stress. And what I do when my patients are first diagnosed, I tell them, listen, we need to figure out where the real cancer is, because I can treat the cancer in your body, but that man, that woman, that the kids, the job, sometimes those things need to be cut out in order for us to get that peace, so that we can be in a good mind space to get good healing and be receptive and to have our body open and receptive to the treatment.
Mm, good point. Yeah, I think a lot of times too, once you even get that cancer diagnosis, I think you almost become even more hyper aware of ways to really try and reduce that stress, and realizing, okay, you know what? That's so small now. I really need to be focused on this. And you can start to really chip away at those additional stressors. So yeah.
Yeah, again, easier said than done, but
Right. Always keep trying. Lots of deep
absolutely.
breaths. So here's another question. So I'm going to read it just as it's written here. As I understand it, not all TNBC is the same. Are there sub-variances, and should we ask our doctors to test for this?
Yeah, and I think that we as oncologists think there are. We just don't have the data to prove it. Again, it's challenging and mind-boggling, because we'll talk about cases in our breast conference, and we'll have a patient who has a 1 centimeter tumor, but then she has metastatic disease, and it's like, but it's only 1 centimeter. Versus, I had a woman years ago who had a 13 centimeter tumor. It was growing out of her breast. She had no lymph nodes that were positive, and she had no metastatic disease.
What?
It was one of the most amazing cases that I had ever, and she did great, but it just didn't make sense. So we do think that there are, but again, I think we've got to get some women into clinical trials and get those tumor cells so that we can look at that a lot more closely and get some answers.
Yeah, my goodness. I mean, it
Yeah,
goes to show that every body is different, right?
absolutely.
So, do surgery choices impact recurrence rates and outcomes, like the lumpectomy versus a mastectomy?
They can. So for patients that have a lumpectomy and have what we call positive margins, meaning we take the tumor out, then we take out extra normal tissue around that because we don't want any tumor touching that tissue. If those margins are positive or have cancer touching or within them, then that does put someone at a higher risk of recurrence. And we're usually going to suggest more surgery, which people are not happy to hear about that. But, it really is, we want to get the cancer that we are out. We want to get it out. And so when we do that, then yes, the recurrence is higher. When someone has a mastectomy, you can get positive margins with a mastectomy as well. We try not to by giving the treatment up front and trying to shrink the tumor down. But when there is tumor left behind, then that does increase the risk of recurrence.
Mm.
So my really recommendation is, I think a lot of women come into their diagnosis with an idea of how they want to be treated.
Mhm.
And then many times we give the reality of how they should be treated and what our recommendation is. And sometimes it's hard for people to reconcile that. And I've had patients say, I don't have to, you are not taking this breast off. It has cancer all in it. No, I'm keeping this breast. I want to keep this breast. And it can be hard. And I know the choices are hard and the realities can be hard. to hear. But I just recommend that people listen. If you're not comfortable with your doctor, get a second opinion. You can even get a third opinion. And if you don't like your doctor, guess what? You can fire your doctor. It's
Right?
okay. It's okay.
Yeah, I actually divorced mine. That's what I said. I'm divorcing you. I'm finding another that will listen. And like you said, it is okay because at the end of the day, it is your body, and you want to make sure that you can trust your medical team.
Absolutely.
Right?
And you don't want that stress of, it's like you go in every time and you see that doctor and you're like, yeah, just not really here, but I know I should be here. That's adding stress as well. I think you really want to be comfortable with your team because it's already an uncomfortable situation. So I really am a big, we've got to advocate for ourselves. And not every doctor is for us. And that's okay.
Right.
It is okay.
And also, too, it is a very personal choice. And, once you get the information from your oncology team on what, they suggest, the type of surgery that you should have. But at the end of the day, it's be informed. You're taking into account your genetic testing, your pathology, your family history, and all of that. So it's a very personal choice. That's what I like to tell other women too, that don't ever let someone's surgery shame you if you got something different.
Right. And there's just a lot more options with surgery now. So, because we can do what we call the oncoplastic approach. So those patients that have a breast reduction, we can now actually take out larger tumors in someone that has a larger breast. We can take the tumor out, we can lift, reshape the breast, and that's considered a lumpectomy or partial mastectomy. So, things have changed. I think ask a lot of questions. And again, don't be afraid to hear the information from another provider and get their opinion.
We've received quite a few questions about this. Can you tell us, or what do you know about zoledronic avid reclass? Can you discuss this medication? Am I saying that right? Zoledronic?
Yeah. So that's one of the medications that's used to help with bone loss. And so the oncologist will give that. Now, I'm not sure all the indications that they use for that, but it is help to rebuild bone and bone loss.
Okay. So I hope because that was asked quite a few times actually. So it seems like some patients are hearing about this. Let's see. Earlier, how can we locate a nutritionist after treatment? Because there's so much misinformation and, reducing stress, also trying to eat right. But what does that even mean? What would be your advice to patients who are wanting to learn how to eat better?
Yeah, nutritionists are hard to find, fortunately. I think there's some online resources that you can use. I think the larger cancer centers have that nutrition support. So I would say try online and or to check with your doctor or at your health system and see if they have nutrition support there. Nutritionists are unfortunately hard to find.
Right. We'll make this, got two last questions here. This one, what does invasive mammary apocrine endocarcinoma mean?
Invasive, it sounds like invasive mammary.
Yeah, invasive mammary apocrine endocarcinoma.
Yeah, so invasive mammary is a term where the pathologist is really describing that the cancer is both in the ducts and in the lobules, versus you can have invasive ductal where it's just in the ducts, or invasive lobules where it's in the lobules. Invasive mammary is a term where they see it in both the ducts and the lobules. And that's usually what you'll see on the pathology report.
Okay. Here's a really good question. What has been your patient's experience with Keytruda? we have a listener here that says their mastectomy, they had breast cancer 10 years ago in the same breast, and it was delayed by 6 months due to colitis from Keytruda. So can you give any experiences of your patients who've been on Keytruda?
Yeah, I mean, it's still fairly new and fairly evolving because it was just for, originally it was for metastatic, and then they've just opened it up to, patients with early stage cancers. I haven't had any patients who've had any severe reactions yet, but again, I'm on the surgery side versus the oncology side. But, I know that's why the oncologists really follow the patients very closely during treatment. Because they want to know if there are any changes or any other reactions so that they can step in and get those treated.
So I think it's important, always communicate with your oncologist if you're feeling strange side effects or what have you, or any side effects. So it is noted, especially if you're starting something new.
Absolutely.
Well, one final question. So with triple negative, they're not able to be on a, hormone blocker or anything. What do you say to patients when, it's over and they have no medication, to take? What do you say to try and help reduce that fear?
Yeah, it's tough even on our end. And so I think it's, we just try to be encouraging, especially, now that we've changed the order and doing that chemotherapy up front. And that really gives us a guide on if we see a really good response, then we know that the patient is going to have a better outcome. But it's just being encouraging. We know it's hard not to think about it. And again, I'm going to plug clinical trials again. I think it's, with more triple negative patients getting into clinical trials, us getting more tissue so that we can evaluate it. So that gives those hardworking researchers something that they can look at and try to design something. I mean, I'm hoping one day we will have a pill that triple negative patients can take in the future.
You know what, everyone? You heard it here. Look into clinical trials, and we'll make sure that we link to some clinical trial information as well once we make this video available for the masses. So don't you worry. Well, Dr. Regina Hampton, just thank you so much for your brilliance, but really breaking down the information about triple negative breast cancer and all of the new information regarding staging and the surveillance afterward and the prosthesis information, which is so great. We really appreciate that. And as you said, we do have more options now. And I think it's always important as patients and their caregivers to stay abreast, pun intended, on the latest information and know that there are choices. And at the end of the day, always keep that communication open between, yourself and your medical team. So
absolutely.
We hope to have you back again. Thank you. And as we wrap up, everyone, just want to say, make sure to check out our upcoming programs. Make sure to go to sharecancersupport.org. And you're also going to receive a survey at the end of this webinar. The survey will show up in the browser when the webinar ends, and the link will also be in the follow-up email. And remember, all surveys are anonymous, and we will also make sure when we send out the follow-up email that will add some links to clinical trials. And once again, thank you all for attending, and thank you again, Dr. Regina Hampton.